Good morning, everyone, and welcome. I'm Angela Jones from the Monash Partners team, and it's my great pleasure to welcome you to today's event. I am the proud leader of the Monash Partners Consumer and Community Involvement Platform. For those of you who perhaps may not have attended one of our events before, Monash Partners is a National Health and Medical Research accredited research translation centre. It's a partnership that brings together 12 health service teaching and research organisations serving a population of about 3.5 million people across the southeast of Melbourne with reach into regional Victoria. Our purpose is to connect researchers, clinicians and the community to innovate for better health. And we've established a consumer and community involvement platform to undertake research about consumer and community involvement, build capacity across our network and collaborate with national and international leaders in this field. We've been delighted to partner with the National Health and Medical Research Council around their annual Research Translation Symposium, which is an event that's been happening over the last 3 to 4 days. And this is a satellite event within that broader program. We begin by acknowledging the traditional custodians of the land on which we're meeting today, and in a spirit of reconciliation, I acknowledge the Wurundjeri Woi-wurrung people and Boonwurrung people as the traditional owners of the land on which I am standing today. I recognise their connection to land and role in caring for and maintaining country over thousands of years. We pay our respects to elders past, present and future, and extend that respect to all Aboriginal and Torres Strait Islander people joining our webinar today. I invite you to introduce yourselves in the chat and acknowledge the traditional custodians of the land where you are joining us from. Today, Monash Partners is proud to present Better Together, exploring the current state of consumer and community involvement in research. Our program includes a keynote address by Professor Andrea Tricco, as well as followed by an engaging panel discussion with researchers, academics and consumers across the Monash Partners network. We've planned a thought-provoking session exploring some of the beliefs and values and motivators that underpin consumer and community involvement, as well as some tangible examples and innovative approaches to effective consumer and community involvement. Just as a couple of housekeeping things, we are recording the session and we will make a copy of the recording available on the Monash Partners website and via email to you following the completion of today's webinar. There will be opportunities for us to hear from people attending, so please, comments and questions in the chat are most welcome. And now it is my great pleasure to introduce our first speaker, Susan Biggar. Susan is a former writer who now works in health regulation, leading change in a national health organisation. 2 of Susan's adult sons live with a serious health condition. And this was, I guess, the catalyst for her becoming really involved in consumer and community involvement. And for nearly 2 decades now, she's served as a consumer representative across a broad range of organisations. Since 2013, Susan has been involved as the co-organiser of an annual fundraiser supporting high-quality medical research in Australia. And to date, that organisation has very successfully raised almost $1 million for research that responds to community needs. Welcome, Susan. Thank you for providing a consumer perspective and setting the scene for our seminar today. Over to you.
Thanks, Angela. It's great to be here. So for 27 years, I have been focused on medical research, believing that it would be the best hope for our family's future. Because my 2 eldest sons live with cystic fibrosis, so we've seen all sorts of interesting solutions, probably mainstream medical big hopes. We've seen them come and go as the game changer for CF, for cystic fibrosis. There was pulmozyme, high-dose ibuprofen, turmeric sprinkled on their food, even in their drinks, poor kids. Colchicine, a gout drug. The list is long. Our family has always put up our hands to be involved in research trials, or probably more accurately, I put my hand up for us before my kids could, the poor things. Because I believed in research as the hope, as the answer for my kids. And because I had, and I continue to have faith in all of you, smart, hardworking, committed researchers who are really working their tails off in the lab to come up with ideas that might work to defeat this, what's really a tough, exhausting, and a disheartening genetic condition. And if you're a parent, you'll know why I was so focused on this, because when my eldest son was born 27 years ago, and diagnosed with cystic fibrosis, the average life expectancy was 27. I was 32 when he was born, and I couldn't bear the idea that he might not even live to his 30th birthday. So really, I had no choice but to do whatever I could to change what seemed like a certain future that I couldn't and really wouldn't accept. So about 15 years ago, I had 3 young sons. They were 12, 9, and 5, I think. And I was trying to claw my way back slowly into the career that I had dumped when CF first overwhelmed me some years before. But we still had 3 very young, busy people. And one of the ways we worked to keep them well was exercise. So there was swimming and hockey and basketball and soccer. And in the middle of this, I remember that I was asked if I would participate in a new drug trial with both kids, both who had CF. And my typical response was to say yes to every drug trial going. Sometimes I hesitated on the ones with a lot of blood tests because one of my kids had a needle phobia. But this was a new nebulized drug, which had the potential to be amazing. And it needed to be done 4 times a day, 15 minutes each time, times 2 kids. That's 8 nebulizers a day or 2 hours of nebulizing. So we decided in order to do this, we would have to do them like this: once before school, both kids, once in the car on the way to after school sports, I'm not kidding, once before dinner, and then once before bed. Plus each nebulizer had to be washed and dried between use. Luckily, we had a lot of them because we still had our other nebs to do 2 times a day, plus physio 2 times a day, times 2 kids. Both the kids had pills 2 times a day and enzymes with every meal, so on and so forth. And I did wonder at the time if this was realistic for anyone, because I'm, a pretty, I'm willing to try anything, but I did wonder. And I wondered, had the researchers thought about the feasibility of this? It might work in a hospital, but most people with CF, thankfully, were like my kids. They had periods of time in the hospital, a couple of weeks usually, but generally they were busy and they were trying to live well while staying well. But how could I say no? So we started and we went on with it for about 6 weeks until everything started to crash. I can still remember, even though it was 15 years ago, I still remember picking up the phone and calling that lovely lead at the research team at the Children's Hospital to say I was pulling out. It just wasn't feasible for me or for our family. Now, you might be sitting there thinking, I'm a really busy person too, with a full load of research grants to acquit every year and so many applications to do. And I've got HR issues, not to mention my own personal life complications. And you're thinking, I know where this talk is going. This woman is going to tell me, this consumer, that somehow I need to make room for her and for other patients and families like her in my increasingly complex and overburdened research program. And yes, I am going to say that. I'm going to go one step further and say that you don't have time to not include us. And none of us have time for you to do medical research for drugs and treatments which are not going to be manageable for us, like the nebulized drug, which didn't end up going anywhere. I can't even recall what it was called now. You don't have time to solve the problems that aren't making our life hard when we desperately want you to solve the ones that are. And after nearly 30 years of being on the receiving end of research, again, for which I'm exceptionally grateful, I'm convinced that collaborating with patients and families, recipients of your work, is critical. So for years, I was involved at the Children's Hospital with the Family Advisory Council, and I was a member of a number of committees. And I learned so much from families who had spent years in the hospital, something thankfully my family really never had to do. I couldn't represent them without hearing their voice and acknowledging the barriers to them having a voice. Because I have a kind of a big voice myself, as you can tell probably because I'm here doing this talk. I have an advanced education, I have supportive networks, and I knew how to speak the language of staff. And I wasn't afraid of the discrimination that I might face because of speaking up. But other families were, and they are. And those families, they taught me at the Children's that they taught me all sorts of things. They taught me we needed to make parking affordable, that families needed to be able to bring their own food into the hospital, that families from the country, which I wasn't from, needed all of their appointments on one day. They needed to have daycare for their other kids. They needed help with interpreting. I didn't understand those things because I hadn't lived their reality. And you probably haven't lived with CF. But you need people like me at the beginning, the middle, and the end of your work. And as I said, people who might not look and sound like me, but who have medical lived experience. Because we will give you ideas and we will tell you straight away if your ideas don't make sense. And we'll jump for joy and let you know when they do. We'll be honest. We won't have an opinion about things we don't understand or don't have specialist knowledge in. And we're not going to be emailing you every day or be annoying for you. But we will advocate for you, and we will raise money for the research if we can have a role in it. Because to be honest, people like me are, I think, sort of done with raising money without a voice in how it's spent. So about 10 years ago, two other CF mums, one you'll hear from later, Julie, and I decided that we wanted to start raising, we wanted to start ensuring that the money that we raised went to research and to the research that we believed was important to people living with CF. So we started this annual fundraiser, as Angela's mentioned, and we have raised what's getting close to $1 million now. We hope it'll tip over $1 million in March of this year. And we've been partnering on this event with Monash partners for several years now. And I think it's a beautiful collaboration because we have the connections with the CF community. So we raise the money. Then we put our heads together with Monash to make a list of priority areas for research. And we say what issues we think are important to our community. Then the PhDs and CF specialists, which we're not, they assess the applications and they rate them. Then they come back to us again and we make the final decision. And it works. I mean, we've still had to tease it out, but it works. And we as the consumers, we all have jobs and families and complicated lives. So we don't want to be looking down your microscope or telling you how to do science. We want you to do that. But we know the CF community, and we know people who, in our circumstance, are willing to walk 65 kilometers in one day to raise $100,000 a year. So you don't have to. So you can do what you do well. I think it makes perfect sense. Involving consumers in research properly at the beginning, the middle, and the end, respectfully, collaboratively, in a partnership. I don't think you'll regret it. I hope if you're at the beginning of this part of your journey, that in a few years' time, you'll find yourself looking back and thinking, how did I ever try to do my best research without consumer and community involvement? And on just a final note, before I finish, and I will, I'm about to finish, can I just say thank you from all of the patients and families whose lives you've changed already and those you will change in the future. I mean, our family still has its health struggles. We probably always will, but we finally do have some game-changing treatments in CF, absolutely game-changing treatments. And for that, we're very, very grateful. And several months before his 27th birthday, my eldest son, who's always been a runner, ran the Melbourne Marathon in 2 hours, 47 minutes, qualifying to run in the Boston Marathon next year. And that is in large part because of the work that people like you have done for many, many years. And it's far behind, far ahead. Many of us living with CF feel that we are, our kids or our adult partners are far ahead of where we might have imagined, certainly for us 27 years ago. So for that, we're grateful. Thank you. And Angela, I'll hand back to you.
Susan, thank you. And thank you for beautifully and passionately setting the scene for our seminar today, telling us about the very personal and enormous value of research to the health of your family. There's nothing closer to our hearts than the health of those around us, and the incredible opportunity to work in partnership, to have research that addresses what's important to people living with cystic fibrosis every day or any other health condition. Thank you so much, Susan. It's my great pleasure now to introduce Associate Professor Andrea Tricco. In establishing the Monash Partners Consumer and Community Involvement Platform, it's been a great privilege to learn from national and international leaders in consumer and community involvement. Andrea comes to us live from Toronto, Canada today. She is Director and Scientist of the Knowledge Synthesis Team and the Knowledge Translation Program at the Ka Shing Knowledge Institute of St. Michael's Hospital in Toronto, Canada. She's also an Associate Professor in the Dalla Lana School of Public Health and Institute of Health Policy, Management and Evaluation at the University of Toronto. And Andrea is also co-director of the Queen's Collaboration for Healthcare Quality, the Joanna Briggs Institute Centre of Excellence at Queen's University. Today, Andrea will be presenting on the strategy for patient-oriented research, which has been developed and implemented in Canada, and an alliance that's developed, and she will also be speaking about patient engagement and some of the key learnings of her centre. Andrea, thank you so much for joining us today and presenting live, and over to you.
Great. Thank you so much, Angela. It's just such an honor and pleasure to be here speaking with everyone today. I'm going to pull my slides and make sure that everyone can see. Just one second, make sure that you can all see my slides. Okay, this should be, one second here, okay, that should be okay, right, Angela? Okay, great. Thank you. Thank you so much. And wow, what an inspiring story from Susan. I honestly had chills, a tear in my eye, and what an incredible speaker for me to go after. And so lovely that, you know, we started your day with the perspective from the consumer. I think that's just absolutely amazing. And that's absolutely where we need to start. So very much real pleasure for me to be here with all of you. So Angela mentioned today I'll be talking to you about the Sport Evidence Alliance and with a focus on what we've been up to regarding patient engagement. So in terms of my land acknowledgement, so we work on land that is now known as Toronto or Toronto, and it's the traditional territory of many groups. So the Mississaugas of the Credit, the Chippewa Ojibwe of the Anishinaabe, as well as the Haudenosaunee and the Wendat. And I would like to personally honor the elders and knowledge keepers, both present and past. And I myself am committed to continuing to learn and respect the history and culture of the communities that have come before and presently reside on the land. So I have personally taken cultural safety training to acknowledge and learn about the harms of the past as well as the present, and dedicating myself to working with and listening to First Nations, Inuit, and Métis communities in the spirit of reconciliation and partnership. So in terms of my conflict of interest, so I did receive a stipend from Monash University for my talk today. And I also received a stipend from the Journal of the Clinical Epidemiology in my associate editor role. In terms of my academic competing interests, I hold a Tier 2 Canada Research Chair in Knowledge Synthesis, as well as several grants to advance knowledge synthesis and knowledge translation. And I am the nominated principal investigator of the Canadian Institutes of Health Research, or CIHR, funded Sport Evidence Alliance. So if I say amazing things about my initiative, it's because I'm the NPI, so take everything I say with a grain of salt. I'm also an unpaid associate editor for Systematic Reviews, and I'm on the editorial board for BMC Medicine and JBI Evidence Synthesis. So for today, I will be talking, giving you a little introduction to our initiative, as well as talking about the patient engagement that we've been working on, as well as something that we call patient co-led queries. So this really is research that is driven by patient partners, and the topics are actually submitted by patient and public partners. I'm going to talk a little bit about capacity building, the initiatives that we've been working on for our patient and public partners, and then also the top 10 learnings. That's what Professor Teed wanted me to focus a lot on, so I'll be spending a bit of time on that as well. So just to give you a little bit of insight into the Sport Evidence Alliance. So this is an initiative where we've received $7.63 million from CIHR, and we received more than $11 million from many different public and not-for-profit organizations. So this is a collaborative initiative between researchers, patients and the public, healthcare providers, and health system decision makers. And our mission is to promote a Canadian health system that is increasingly informed and continuously improved using scientific evidence. Everything we do is guided by evidence-informed methods. So we're trying to ensure the highest standards in research practice. And this is all conducted within an environment that promotes inclusiveness, respect, and collaboration. And everything we do is for decision makers, and we include patient and public partners as decision makers. And we want to make sure that the people we work with are those that are impacted the most by our research findings. So our key activities include this research query service. So this is where we actually have more than 20 teams across Canada that have the expertise to conduct these projects. And so what that project entails would be that a decision maker would come to the Spore Evidence Alliance and they would say, we have a decision that needs to be made in this amount of time, and can you please provide us with information required for us to do this query. So most often our products have been knowledge synthesis. So this has been products such as systematic reviews, rapid reviews, scoping reviews, real list reviews, etc. However, we also provide capacity and we also can help with the clinical practice guideline process, and we also do knowledge translation and dissemination projects. So we match the decision maker up with teams across the country to get that work done. We also provide training and skills development. So this is not only to researchers and to trainees, but also to patient and public partners, and also to our policymaker and healthcare provider partners as well. And we have a focus on ideas and innovation, and that we aim to promote and advance the use of scientific knowledge. So just to get into some terminology, because you've been hearing me say patient and public partners. So why am I using this terminology? Well, it's because our Canadian Institutes of Health Research, or our national funding body, has set this language for us to use. And so, as you know, I'm hearing that from Monash and from Australia, we have consumer and community involvement. And then when we think about the UK and Europe, we hear the term patient and public involvement, or PPI. And then in Canada, we use patient and patient engagement and patient-oriented research. So these are the terms that we use. So when I use the term patient, it's actually overarching, and it's inclusive of individuals with personal experience of a health issue, and also includes informal caregivers, including family and friends. So have heard before that, some people don't like the term patient because it could potentially be stigmatizing. And, that's something we could potentially work with our national funding body at some point. But for now, they want us to use the term patient. And that's within our title for SPORE, which is a large enterprise across Canada that our national funding body has been funding for more than a decade. And patient engagement focuses on meaningful collaboration. So patients become partners in the project. They're actively engaged in the governance and priority setting, in developing the research questions, and performing certain parts of the research. So if you think about Susan's first talk, that when she was just speaking, she said, patient partners have to be involved at the start, in the middle, and at the end. So absolutely, according to our definition in Canada, we would absolutely agree with that. And in terms of patient-oriented research, this is a continuum of research that engages patients as partners. It focuses on patient-centric priorities. So the priorities actually come from patients and community members. And we're aiming to improve patient outcomes individually as well as in the community. So thinking about vulnerable populations. And this needs to be done by multidisciplinary teams in partnership with all the relevant partners, and aims to apply the knowledge generated to improve healthcare systems and practices. So in terms of some foundational principles for patient engagement, so this was an article published by Harrison and colleagues. So some of those principles include respect and equity. So thinking about diversity, authenticity, integrity, and confidentiality. Also building trust, so transparency, honesty, and empowerment. So shared decision-making and ownership, flexibility, as well as institutional support. And some of the engagement best practices include providing research training and education, making sure that you have role clarity, and matching partners with the community, engagement, budgeting, and compensation. Also focused on evaluation and reinforcement of the engagement activities, overarching engagement structure model. So we'll use a patient or a family advisory council model or other types of models. Research team communication is incredibly important in how you organize those meetings. And then how are you going to sustain that engagement and reinforce that over time? So I really like this, this framework because it summarizes a lot of details. Actually, my whole talk is summarized right here in this one slide. And I also like that it has across the bottom here the research phases. So design and preparation, conduct and implementation, as well as dissemination. So you may be wondering in the audience, I may not have convinced you about this, but what is the effectiveness of all this? Like, it takes a lot of time and energy. So why would we invest our time in doing this? Well, you'll be pleased to hear that a very high quality systematic review and meta-analysis of 131 studies has shown that patient and community engagement is highly effective across a range of outcomes. So health behaviors, health consequences, participant self-efficacy, and participant social support. So if you are a data type of person, I would highly encourage you to read this article published by O'Mara, Eves, and colleagues in 2015. And basically the summary of this piece of work would be that we know that community and public engagement works. However, what we don't know is the most effective way to do it in terms of what is the dose, what is the intensity, what are the combinations of interventions that we need to do for this to happen. So that's definitely something for us to do some future research on. However, that to be said, we do know that across all of these outcomes, and these were all statistically significant outcomes, that we do see that it is a highly effective thing to do. So in terms of what we've been doing with the Sport Evidence Alliance, we've received more than 148 requests, and we responded to 124 when it comes to query services. And it is an inclusive research service. So as I said, we accept requests from everyone, so patient and public partners included, health system decision makers. And if you are interested in learning more, there is a nice video here, a link to a video that has been recorded using very lay, simple terms so anyone can understand it. We don't have time today for me to play the video for you, but if it seems like it would be something of interest, I would encourage you to watch that small video. So for our health system decision makers, so many of our queries have come from health system decision makers. So they basically come to us and we ask them, what is your decision? What's your timeline? You know, what would be helpful? Do you need to know something like, does this program work? Then maybe we need to do a systematic review for you. Do you need to know what programs have ever been examined in the literature? Then maybe we need to do a scoping review, etc. So we do work very closely with the decision maker. And like I said, we have more than 20 teams across Canada. We match them up. We try to match them up locally whenever we can with those decision makers. And we provide a lot of support and guidance to the actual research teams. So we provide them with capacity building on how to do proper patient engagement, because for all of these projects, we expect that they engage 1 to 2 patient patient and consumer partners on every project. So we have to give them a lot of guidance on how to do this. We give them ongoing coaching. We also give them with resources. So one example is our freely available Write Review tool. So that's when you answer a series of simple questions, and based on your responses, the tool will tell you, okay, based on what you've said, it looks like a scoping review would be the most suitable or most appropriate review to answer your research question. Or based on what you said, a realist review would be helpful, or a rapid review, etc. We actually have 41 different types of knowledge synthesis in there. So if you think that that would be a tool that could be helpful for you, definitely look at check out that resource. We also have an artificial intelligence tool, and this is to help them screen, taking the screening and literature knowledge synthesis down from months to weeks. So we provide the teams with tools so that they can really focus on engagement. And then everything that we do is tailored to decision makers' needs. So our query service, the heart of it is co-creation. So the definition that we use was published by Dr. Greenhall and colleagues. And so it's a collaborative generation of knowledge by academics working alongside partners from other sectors. So the spirit of co-creation is to invite multidisciplinary and diverse knowledge users as equal members of the research team to produce the research alongside researchers and to create a sense of ownership. So we all feel that we own this product together. And by working together towards this common goal, the sum is greater than the parts. So if I can direct you towards this paper on the right, so this is actually a paper that I'm probably the most proud of in my entire career. So it's in BMJ Open, which is a fantastic journal, but it's not the highest impact publication that I have on my CV. However, in this project, we co-created a systematic review. I have 4 policy decision makers from the Public Health Agency of Canada as co-authors on this systematic review. There's a patient partner as a co-author. We have 2 trainees on here and 2 clinicians, so 2 geriatricians. So to make this happen takes something, and is something that I'm incredibly proud of, and that not only was everyone pleased to be a part of this, they felt ownership of this, but to put their name on it really shows the sense of this joint collaborative product that we created together. And this was used for decision making. So it was used to develop an intervention strategy about social isolation and falls for the Public Health Agency of Canada. So in terms of our query services, so we have a whole focus on early career researchers. So we've had 20 that were led by early trainees, early career researchers. And then we also have 63 queries by our trainees. And just to say that our co-creation model resulted in more than 194 decision-making engagements and more than 180 patient and public partnerships. And we've disseminated our research in various forms just to reach broader audiences. And the fact that we're using co-creation as a model and as a core principle for everything that we do, people feel ownership, they're excited about the project, and they want to share it across their network. So that is actually a knowledge translation dissemination strategy in itself. So the huge focus really is on the patient and public query process. So this is a separate process from the one that I described that would be focused on policymaker and healthcare providers. So every year we accept research topics that are submitted by patient and public partners. And how do we get these topics? Well, we do a lot of outreach. So we have a huge network of patient and public partners in Canada. We do quite a bit of email outreach, a lot of word of mouth, a lot of networks that we tap into, and a lot of social media campaigns. So this is how we've received topics from patient and public partners. And then we prioritize these. So we want to focus on the most impactful. Also, part of our whole initiative is to reduce duplication and make sure that we don't have any research waste. So we want to make sure, if this question has been answered before, then what we do is we write a 1-page lay summary for our patient and public partner and say, here's the answer to your question. It's already been addressed in the systematic review, as an example. So we try to do this whole process where we prioritize and we focus on the most impactful ones, and also the projects that have not been done before. And we have a panel of patient partners, clinicians, policymakers, researchers, and trainees who come together. We do several rounds of voting. We use kind of a modified Delphi approach, and then we would select the top ones that are going to proceed. Now, when we've selected the topics to proceed, the patient and public partner becomes the co-lead of this project. So the work plan, so basically the protocol, the budget, and research findings, this is co-developed by patient partners and the research team. So we have these patient partners who co-lead the project, and we also invite other patient partners to come and co-create the project with us, as well as policymakers, as well as our healthcare providers, so that we have a range of different perspectives on every single project. And again, we try to provide capacity building, resources, and guidance to our patient and public partners, similar to what we would do with our research teams, just to make sure that everyone is aware and understanding of the process. So I'm very proud to let you know that over the summer, we received 87 topics, and the top 20 will be proceeding to full projects. So we received extra funding from our Canadian Institutes of Health Research to do 20 additional projects. So something that we're incredibly excited for, these projects that are actually suggested by patient partners and co-led by patient partners. A couple years ago, we actually did our first round of prioritization. And just to give you a flavor of the types of topics. So these are topics that came from our patient and public partners, okay? So one of them is gonna be a review looking at patient and public partners in writing lay summaries. And we have the team here. So the patient partner lead is Joanne Mosel, and the researcher lead is Dr. Heather Cahoon. Then we're looking at alternatives to institutional care for older people. And so the patient partner here is Elliot Post-Jensen. And then the researcher partner is Dr. Elaine Moody. And then we're going to be also doing a project on trauma-informed care practices to support caregivers. The patient partner is Bev Pomeroy, and the researcher is Dr. Lindsay Jibb. So you see here a range of different topics. These topics came from the patient partners, and they're co-leading these projects. So now within the next 2 years, we're going to have 23 projects like this that are completed where we've worked and engaged with patient partners in this way. So something we're incredibly excited about. So just to move on a little bit about some of our training capacity and development. So we've had more than 140 learning opportunities, and we've reached more than 3,300 learners since 2017. And something that people ask us about all the time is, do you provide capacity building to patient and public partners? And absolutely we do. So in 2021, we did quite a few rapid reviews, and on all of those rapid reviews during COVID, we did like more than 50. Our policy decision makers kept us very busy. And so we wanted to do a course for our patient and public partners specific on rapid reviews because they were getting engaged. So on every one of those rapid reviews, we had 1 to 2 patient or public partners as part of the research team. So this was a 3-week course, and it was co-led by 2 patient partners, so Maureen Smith and Janet Gutterson. And we had 24 participants across Canada in this first iteration. It was a very highly rated course, and we had a very high response rate. And then since then, we were able to match all 24 graduates with at least 1 project. So they've participated in 18 projects since June 2021. So that's a little snapshot of one course that we've provided to patient and public partners. This year, we just finished our next cohort of patient and public partners. This time it was broader, so it was actually on knowledge synthesis, because since the rapid review course and since 2021, we've been having patient partners engaged on systematic reviews, on scoping reviews, on network meta-analysis as well. So all kinds of different types of knowledge synthesis. So we felt it would be important to give them some high-level training and capacity about these different types of knowledge synthesis. So again, this course was co-led by 2 patient partners. So it includes live interactive online sessions, quizzes, learning modules, and reflection boards. We have 23 participants across Canada, and course evaluations are currently underway. And just to say that we actually provide compensation to the patient and public partners who took this course. So all of the participants in the course got paid for all of their time. So now I'm going to move on to the top 10 things that I've learned about patient engagement. So number 1 is providing training to researchers. So oftentimes, I think as researchers, we think, oh, we need to provide training to the patients. And I would say, based on my experience, it's actually the researchers who need the training and capacity building to do this very, very well. So one thing I would say is that I think it's really important for researchers to do cultural safety training. This is even if you're not working with Indigenous populations. So I think it's just important to think about some of the inequities that exist in our system and to be aware of those, and to recognize that when people are coming together, there might be different factors that people are facing in their lives. So it's really important for us to learn about that and to really know about that and make sure that we're providing a very safe space for everyone to freely engage. Another important thing is for researchers to receive training on trauma-informed approaches. Again, you know, even hearing from Susan's story, that as a mom, for me, that sounded, you know, like that would be very triggering, and sitting in those research meetings might be challenging. And you know, I think for us to learn about trauma-informed approaches from a researcher's perspective, what it gives us is a sense of compassion, and it can help us understand that a patient or a public partner sitting on our team could be triggered just by participating in the meeting. This is very emotionally charged lived experiences that people are going through. So I think it's really important for us to always come from a place of compassion, and for us to be aware of some challenges that people may face. So trauma-informed approaches are very powerful and can help us with that. Providing training on good patient engagement principles and effective co-creation, as well as on learning how to plan for engagement, because it does take a lot more than just doing your regular project with researchers and you're done, right? Like this, it does take time and energy to do this really, really well. And then when it comes to providing training for patients, I think it's more just a very high level overview of the research process. So we're not expecting them to become scientists. I get like it might sound kind of, you know, like self-explanatory, but I honestly get asked this all the time. So, oh, will the patient partner become a methodologist? No, they're not going to become a methodologist. The expectation, their role on that team is that they provide the lived experience. Okay, so what we need to do is facilitate that to them so that they can understand the process, kind of understand what their role is, and what the expectations are, so that they can fulfill their role of providing us with their lived experience. Also, if it's something like the co-leading type of project that I talked about today, guidance on that. So what is there now? This is getting a bit different because usually we have researchers that are leading the projects. And so the researchers still are leading the projects. The patient partner is co-leading that from a perspective of a lived experience. So how can we facilitate that for them? How is there extra training? Like some of the patient partners that we've been working with have gone out on their own, and they've done more training on leadership and being a leader, and that has been really helpful for them. So anything that we can do to support them in that role, because it is a unique role and something that you know, typically we haven't done as researchers. So I've kind of mentioned this, so creating a brave space so you can co-create your principles, terms of reference at the beginning. So, you know, our principles are that we treat everyone with respect. With co-creation, you're gonna expect disagreements to happen. You wanna come from a growth mindset and thinking that those disagreements are actually gonna lead to better science. It's going to expand our thinking, expand our horizons. So always coming from a place of, that's an interesting perspective. I never thought of it that way. You know, let me challenge my own thinking about this. And is there something new here to be learned? So you can write those terms of reference for the team and make sure that everyone follows those guiding principles. Something that we do for every project, we have a self-reflective exercise on power and oppression. This is something available on our Sport Evidence Alliance website. So this is something we recommend all the teams to do. And just to say, because we now have patient and public partners, we may have policymakers, we may have healthcare providers, researchers, trainees, there is going to be some imbalances here of power on the team. So how do we reflect on our own lived experience and maybe the advantage and disadvantage that we faced in our life, and thinking, you know, who's actually engaging, who's not engaging, who has been speaking up freely, who hasn't been. And that can be a very useful exercise to be done on your own, not to be shared because it's very personal, for you to think about, well, who are the people on their team, on my team, and who may have been experiencing oppression, and is there anything that we can do to make sure that everyone here is able to be freely expressed? Providing support on specific projects. So we want to ensure, like Susan was saying, that patient engagement begins even before the question develops, okay? So I have an experience where the question that came from our policy decision makers was actually of zero importance to the community, right? So if we have limited time and budget, do we want to be working on projects that are not going to have any impact and are going to be stigmatizing and make, you know, the community even worse off, or maybe even increase inequities? Absolutely not. We don't want to do that. So I completely agree with Susan that this actually needs to be even before your question is developed. So you can get a question from a policy decision maker and pass that by a community or a patient partner and say, what do you think about this? They have lived experience. They experience the health system in a very different way than we do. They know the health system more than any of us do, okay? And even more than people working in the health system, because they have a different perspective and they're actually encountering it in a very different way. So super important to make sure that we are asking the most relevant questions that are actually going to have an impact. So absolutely do this. Letting the team know that you need time to develop these relationships before the project starts. Okay, so that's another, relationship building is huge in this work. Engaging more than one patient partner. So we've heard of the lonely only patient. So we try to include more than one. Sometimes we're only able to include one. And oftentimes with patient partners that we worked for many, many years, they're okay with that. That to be said, you know, it is important that they do feel that they have another partner on the team and that they do have a voice. And sometimes when you have more than one, it just helps them with that. Also discussing compensation. So we don't want to ask our patient and public partners to volunteer their time to work to help us. If we're getting paid, they need to be getting paid. And, you know, sometimes I've had a patient partner who said to me, you know what, Andrea, I can't accept payment from you, but can you please donate, you know, my payment to a local mosque? And absolutely happy to do that. So you need to be flexible with that. You need to discuss what they want, you know, what would be helpful. Sometimes they've said, you know, I can't, I'm on disability. You know, I said, well, what can be helpful for you? Well, my computer is old. Could you buy me a new computer? Absolutely. Right. So you need to make sure that we're not creating even more inequities by asking people to donate their time for free. Okay. And also discuss acknowledgement. And this is at the beginning of the project. So sometimes the medical condition might be stigmatizing. They may not want anyone to know. They may not want to be named. So say to them, you know, would you want to be named? If so, can I acknowledge you? Or do you want to be a co-author? Of course, if you fulfill our criteria for authorship, so the ICMJE criteria. So you have to contribute intellectually to be a co-author. And is that something that you're interested in? So have all of these discussions at the very beginning. And finding ways to bring the patient voice closer to policy or practice decision-making. So for example, we invite our patient and public partners to our team meetings with the policy decision makers. We ask them always for their advice, their guidance, their thoughts, their perspective. In our executive summary, we have a section that says patient interpretation of evidence. The patient partners can put whatever they want in there. That's how they interpret the evidence. So trying to find mechanisms and ways to bring that closer, because it's a lot more impactful when we find a question that is of importance to the community as well as to policy decision makers. Communication is key in this work. So you may need to have someone on your team as a liaison to answer all their questions. You may have to have calls with the patient and public partners before the meetings with policymakers, between the meetings, before the research team, one-on-one. You know, you have to have mechanisms for that to happen. And include diverse partnerships. So for every single project now that we do, we recommend a clinician or healthcare provider, a policymaker, a patient partner, and trainees on everything we do. And as I mentioned, viewing disagreements as opportunities for growth and leading to better science. Evaluate patient engagement. So the first thing that we're doing with this work is we don't want to do any harm. So again, you don't want to be causing more inequities by doing your patient engagement. So continuous improvement, you can use an appropriate tool. So one that we like to use is the patient engagement and research scale, or the PEERS 22. find opportunities for patients to submit topics and co-lead projects. Okay, so advocate for this with your funders, striving for the empower level of the International Association for Public Participation. So the highest level is that the patient and public partners actually hold the funds themselves. So finding ways that we can do this. And again, this is to increase the impact of everything that we do and finding that synergy between what would be important to patient and public partners, as well as our policy decision makers and healthcare providers. And report on your patient engagement. So one tool is the guidance for reporting involvement of patients and the public, or the GRIP2 reporting checklist. Trying to embed equity, diversity, and inclusion in all that you do. So many organizations, I'm sure your national health organization is trying to reduce health inequities. Our health funding body is. So how can you embed everything into EDI, into everything you do? So we bake this into our protocol. So at every stage, we prompt researchers to consider EDI at the research question stage, at the literature search screening stage, at the data abstraction collection stage, et cetera, et cetera. If this is something that's of interest, definitely reach out to me, because we just published a paper in the Journal of Clinical Epidemiology on how to do this. And ensuring that you engage with diverse patient groups. So when we've evaluated this in the Spore Evidence Alliance, the majority of people that we were engaging with were usually women, and they were middle to older age, and they came from medium to high socioeconomic status. So we want to make sure that we are diversifying. Again, that takes time and relationship building to do that properly. And so my job as the NPI of the Spore Evidence Alliance is to do whatever I can for the researchers to make the process easier. So I'm always trying to provide them with tools, such as our AI tool. I'm also trying to provide them with templates, protocols, reports, everything so that they can actually focus on the most important thing, which is engagement, versus being bogged down with the whole research process. And if this sounds of interest to you, please consult our series of papers on the Spore Evidence Alliance. So this was published in the Facets Journal, and you can learn more about what we've been working on. So thank you so much. I am now going to stop sharing my slides, and I think, Angela, we have a few minutes for a few questions.
Andrea, thank you so much for your presentation. Wonderful to hear about the innovative ways that the patient and public voice is truly being brought to the fore, and that research is able to address those questions. I just love your approaches. I'm going to hand over to Helena, who's going to facilitate some Q&A now, and there's some questions that have come through. Thanks, Helena.
Thanks, Angela. That was terrific, Andrea. I think when we first met and you were telling me about this, I thought it would be fantastic to share, because I do think we, obviously are progressing things in Australia, but there's so much more we can do. So I think you've answered some of the questions in the chat, to be honest.
Yeah. Okay.
So, some of them asked about what you're doing about equity, and I think you've addressed that. One of the questions was about how you engage with patients who have low digital literacy, especially in the times of COVID. So I don't know whether you'd perhaps like to address that, especially multilingual digital tools and things.
Yeah, no, thank you. I mean, so we try to provide technical support. We try to have calls in between the calls and the presentations to make sure that people are able to access. And, we do try to translate, because in Canada, we're bilingual, English and French. So we try to use lay summaries. So those would be written by our patient and public partners, and we try to make sure that they're available in English and French. So we try to use a range of ways. But even with our course, we had a few patient partners who were frustrated with our platform, and we had to give them a lot of extra time and support. So I think it's important for researchers to build that into whatever you're planning to do.
Yeah, terrific. Thank you. There's a few comments in the chat about whether people will be able to see the slides or the presentation later. So just to reassure you that we have captured Andrea's talk, it's filmed and recorded, so that this will be available for people to look at as well. There were some questions about whether you go beyond English and French, and a few other questions about language, but I think unless you had something specific to add to that, Andrea?
No, I mean, we're bilingual in Canada, so we focus on English and French at this point. Yeah. Yeah.
Okay, not a problem. Thank you. I'm just catching up with the last ones. There was a question about, so there's lots of positive feedback, Andrew, especially
thank you so
great
much.
comments. So just to share that with you. But there was a question about policy decision makers and whether that covers professionals who work in regulatory bodies as well.
Exactly. Yeah. So that would be like a policy manager. So even like our hospital administration, we would classify them as a policy decision maker. So we've done projects with them as well. Yeah.
Okay, great. So I have a question,
Yes.
and it's one of those loaded questions. And you touched on it when you were giving your talk. But the whole concept of the term patient.
Yes.
And obviously a term is whatever a term, whatever it can be. It can either be stigmatizing, empowering, derogatory, depending on the way it's contextualized. Given that you've settled on patient rather than justifying that, I wonder, or arguing for one way or the other, because I think I personally think there are real challenges with the word consumer, for example, which is where Australia's landed. But perhaps in terms of the way you're using patient and ensuring empowerment, what sort of strategies do you take around that?
Yeah, I mean, one thing is even asking, because sometimes when you have members on your team and if you get the feedback that I don't want to be called a patient partner, then, you're going to not call them a patient partner. And so sometimes I'll even ask, like, what is your preference? And I've had people say, oh, knowledge user partner I'm happy with, or sometimes we engage with Indigenous and they like to be called knowledge keepers. So, sometimes they want to be called elder knowledge keepers. So sometimes it's good just to ask whoever you're working with, what would be the type of term that they would prefer. And then, from the reason that we call it, like, you said not to go down that rabbit hole, but just because we are SCORE according to our CIHR funding agency. So we use the term in everything we do, patient and public partnership. And when I'm working individually with people, I ask them, what would be your preference? Because exactly like you said, people may prefer one term over the other. And I'm fine to call people whatever, that they would be most comfortable with.
Right. Thank you. Great answer. Do you involve industry in your work at all?
No, we're not allowed to because it's national public funding that we've been asked to do some projects, even arm's length from industry, but we don't want any potential for conflicts and whatnot. So we haven't at this point involved any industry.
Great. Yes, we have similar challenges with those sorts of things. So there's a question here about when you're mid-research. So this is somebody who's perhaps been doing a very longitudinal study, didn't necessarily start with public and patient involvement or consumer involvement, and then wants to now engage it sort of along the journey with the intention that they really couldn't necessarily do it at the start. Any advice on how you do that?
I mean, I think anything is better than nothing. So even if you're trying to do it at the start, you may not have the capacity, you may not have the time, you may not have the resources. So I think anything that you can do, it's all about finding the right people, making sure they're okay with coming in midway. And, you can say, listen, we want your feedback on what we've done, make it clear whether they can change things or not. So even sometimes we get decisions from policymakers that are set. So I say to my public or patient partners that, you know what, we can't really change the question, but are there sub-questions that, would be helpful? So really clearly outlining what can actually happen or not with the patient and public partners. So you can say, listen, we're engaging you partway through, it would have been ideal to engage you at the start. However, that's where we're at. We can't really change our question at this point, but if you have one or two outcomes, maybe we could do an add-on outcome with that, or, let them know what's possible or not possible. But at the end of the day, I think any engagement, even if it's at the very end, like we've published papers where, we finished the report and we were all done the research. And then we asked a patient and public partner to write a one-page summary for broader dissemination to community and public members. And even that is better than nothing.
Yeah, that's what we're going to have to move on, but to just one last question, which I thought was quite interesting. And in fact, I might even respond to this as well. There's a comment in the chat about the fact that in Australia, we find it very hard to do remuneration and in grants. And I suppose I might challenge that in that for many, many years now in all my grants, before we started calling it consumer and community involvement or public and patient involvement, we've simply had a budget line for stakeholder and community in patient involvement, Monash Partners, in fact, writes the consumer and community engagement part for well over 100 grants now. And we have no problems with funders at all, including budget in the grant for this, but people just don't think about writing it into their budget. So any tips for people just before we hand back to Angela?
Yes, no, thank you. I love your answer. I completely agree with you. And I would say that sometimes, if we'll build it into the contract, if it's not an official national grant from our funding agency. So we'll try to build that in some way. And I think the easiest way, like how you described it, Helena, is a budget line. So don't forget about it. And even sometimes we'll use other grants to compensate them for writing a grant that we didn't get yet. So you may have to be a little creative with it, but with our funding body as well, we've been able to include that as a line in all of our budgets. Yeah.
Right. All right. I'm going to hand back to Angela and I'll move on, but there are some additional questions. I'll see if I can also put some answers in the chat. So thank you, Andrea. I know you've, with the time it is in Canada, you're going to leave us now, and we really appreciate your input so far, and we'll leave you to your family and your evening time, but thank you so much for your contribution. And we will, just to reassure people, send out the link for the recording and also some of the resources afterwards. Thanks, Andrea.
Great, thank you so much. And email me anytime. I love to hear from people. So please feel free to email me. Love to hear from you. Thank you for the amazing opportunity. Take care. Bye.
Thanks,
now.
Angela.
Thank you so much, Andrea.
Thank you.
Back to you, Angela.
Thanks, Helena. Everyone, now we're going to move into the panel discussion part of our online seminar today. And I'm just going to invite all our panelists who are online to turn their cameras on so we can see you all. We've brought together a group of consumers and researchers and academics from across the Monash Partners Network, and I'd like to thank you all for joining us today and making yourselves available. And first of all, I'm just going to ask you to introduce yourselves briefly to our audience online. And Julie, could I start with you?
Thanks, Angela. So hello, everyone. I'm Julie Noorman, and today representing Consumer Research for Cystic Fibrosis.
Thanks, Julie, and welcome. Sandy, over to you.
Hi, I'm Sandy Reeder. I'm a Senior Research Fellow in the Central Clinical School, as well as an Honorary Research Fellow for Monash Partners.
Welcome, Sandy. Thank you. Karen, over to you.
Hi, my name is Karen. I'm a basic researcher at the Australian Centre for Blood Diseases and chair and co-founder of the Consumer and Engagement Program at the Central Clinical School in Monash.
Welcome, Karen. Thank you. Margaret, over to you. I think you might be on mute, Margaret.
There we're right. You can hear me now.
Perfect.
My name is Margaret Thomas, and I became involved with the Rehabilitation, Ageing and Independent Living Centre through Monash in my role as a carer of my late husband who had dementia. And then later, I also worked for the Department of Human Services in Victoria in the falls prevention and dementia portfolios.
Welcome, Margaret. Thank you. Keith, over to you.
Thanks, Keith Hill. I'm a physiotherapist and director of the Rehabilitation, Ageing and Independent Living Research Centre that Margaret mentioned, and a fairly new centre at Monash University.
Terrific. Thank you so much and welcome to you all. Just for our participants online, each of our panelists is just going to speak briefly and share some of their experiences around consumer and community involvement with you. And once we've moved through these series of brief presentations, then we will definitely open up the floor for questions and comments from the audience. So please keep those coming through in the chat or the Q&A, and we're monitoring that. And Julie, if I could start with you, I think the audience would be really interested to hear a little bit about 65K for CF, and in particular your model to support research that responds to the priorities of the CF community. It's unique, and I guess perhaps your insights around what's worked really well and importantly, what have you learnt along the way as you've been doing this work, and what's it meant to your community? Over to you.
Thanks, Angela. So firstly, I'm extremely grateful to have the opportunity to present to you today and tell you our story. So I've been involved with consumer prioritised research for about a decade now and actively partnered with Monash Partners for most of that time. So if I reflect on my journey, I can thankfully say I've been a part of significant innovation in this space that I know can be leveraged by the consumer groups looking for control over their precious research funding. So I'm just going to step back a bit now and start at the beginning. So I have a 19-year-old daughter with cystic fibrosis, and I suspect many of you would not know much about cystic fibrosis. So CF is an inherited genetic condition that mainly affects the lungs and digestive system. So only a few decades ago, cystic fibrosis was considered a childhood condition, with many people not reaching adulthood. But over the past couple of decades, the tide has turned and we now have more adults in Australia with cystic fibrosis than children. So it is a complex condition, and with increasing age comes increasing complexity. Adding to that, there's about 1,200 different genetic mutations falling into about 5 broad classes. So the variations in genes and classes make CF challenging to manage. So we currently have about 2,500 people in Australia with cystic fibrosis, and there is no cure. So new medications are now available that provide a really solid improvement and even a game changer, but they're really based on your specific genetic mutation. And we have about 10% of people at the moment that don't have any options available, and they're being left behind. So in around 2010, I met with Susan, who you heard from before, and Kathy, and we met at a consumer conference. So we're actually organising the consumer stream of an Australasian CF conference. And it dawned on all of us at that time that we definitely need more research to change the lives of our children, and that within Australia, we had very few people dedicated to CF research and even fewer funding mechanisms. So we wanted to change that, and we kept asking ourselves, how can we create a sustainable culture for CF research within Australia? I'm going to say that again. How do we create a sustainable culture for CF research within Australia? So our vision was to generate an income stream for CF research, and that research occurred in line with our community and donor expectations. So our first obstacle was generating the income, and we've achieved this through an annual 65-kilometre walk through Princes Park and Royal Parks in Carlton. We have been virtual for the past 2 years, but next year we plan to be back in the park. So we've been going now for 10 years and raised just under $950,000, and that's clear of any costs. So our next step was to find the right research partner, and our key requirement was that we wanted a partner that gave us a voice at the table. So we didn't want to make a blind donation to a research organisation, as we'd all done in the past, and I'm sure many of you have also done. We wanted to have a real say in the projects that were undertaken, and we wanted to be able to inform our donors with clear project descriptions and lay terms of what we have collectively funded. And to this end, Monash partners have been exactly what we're looking for. So we have a really strong and respectful working relationship that's making a real difference to people with CF. So moving on to our model, our model is linked to our philosophy, which is that our donors and community are at the heart of everything we do. So we have roughly 6 key steps in our model that I'll talk you through now. So step 1, we sort of call our grant theme discovery. So each grant round, we discuss the current pressing issues facing the community. So we have referenced the cystic fibrosis priorities highlighted from the James Lind Alliance, which is extremely useful, and we talk within our community. So the next step from there is we actually book a workshop to further explore each of our themes. So the workshops include all the teams who support cystic fibrosis. So we have clinicians, we have allied health, we have researchers, we have transplant specialists, people from pharmacology and more. And we invite all the teams from the 3 different Victorian CF centres, and we include the paediatric and the adult services, and of course consumers. So we find these workshops extremely valuable. So we always have our prior recipients present. So it's a combination of celebrating our successes from our prior work and also refining the research question for the grant round to come. So through these rounds, we've even actually stopped some of our themes as clinicians have and researchers have mentioned that very similar projects might be underway in Queensland or Western Australia, for example. So it's a good way to collaborate with all the involved groups and really work out what's achievable at that point of time. So our next step is to finalise the theme. So once we've had our workshop, we sit down with Angela and Helena again, and we sort of finalise exactly what our grant themes will be, and we issue them. So we're actually building a really good database now of all the people that might want to actually apply for a grant in Victoria for CF research, and we continue to actually broaden our net. So from that point, we start to receive applications, which is always really exciting. So all of our applications are assessed and scored by an expert research panel to ensure the research is sound. But at the same time, they're also assessed by our core consumer team to ensure the project addresses an area of high concern. And like what you heard from Susan before, that it's a practical project and we're not asking for our consumers to do something that's going to be really difficult to actually meet. So once we have all of our scores, we meet with Helena and Angela, and this is a really exciting day of the year for us. So we actually talk through all of the applications, the scores from the consumer group, the research group, and we finally land and select our grants for that year. So we're really broad in what we select. So through our last grant round, we included topics such as a new diagnostic approach to guide the treatment of non-tuberculosis microbacteria in CF, all the way through to motherhood and lung transplant. So we're quite diverse in what we fund. And to date, we've funded 23 projects. From that point forward, what's really important for us is being transparent with our community. It's publicising, monitoring and reporting. So all of our grants are on our website with a really detailed lay description, including the primary recipient of the grant and the dollar amount. So for us, it's really important to be totally transparent with our community. And I think that helps the way we actually continue to raise money, because we're completely transparent in what we do. So every year our model continues to grow. So I think after each session we meet with Angela again and assess what we could fix or what we could tweak for next time. So I think continuous improvement is always part of what we do. I think that this whole process works really well for us. We've got true collaboration on what the consumers need. We include our clinicians and researchers as well to make sure we can practically do something in that space. And the constant updates and reporting just really helps keep the whole community involved. And I think that's it, Angela.
Julie, thank you so much for describing the model that you've developed, and it has been a great privilege to work with you. We've learned as we've gone along and refined, but it's a real example of consumers being empowered to there's a very rigorous review process for the research, but the funding is in line with what's important to the community. And Julie, thank you so much. I'm now going to hand over to Karen Alt. I think we all recognise that there's no one-size-fits-all approach with consumer and community involvement, and it looks different in different types of research. And Karen works in very much a laboratory discovery-based environment. And so, Karen, it's just terrific to hear from you today around what consumer and community involvement looks like in the context of your research program and how you've been involving consumers. And I know that you've established a consumer program in the school in which you're based. We'd love to hear a little bit about that. And obviously there have been some challenges and learnings along the way. So any insights you can provide around those would be, I'm sure, of great interest to our audience also. Over to you.
Thanks a lot, and thanks for inviting me today here. So yeah, everything started actually 2019 when I wanted to apply for a grant, and they said, "Oh, you have to involve a consumer." And I said, "What is that? Who do I find one?" And so that's where our program started. So our program was developed and it runs by only volunteers who believe that we need consumers to improve our research and our science outcome. And currently we are nine researchers and 3 advocates. And I'm switching a bit between the wording here between consumers and advocates. I know that usually the word consumer is more used in Australia or worldwide. However, our consumers on the program actually would like to be referred more as advocates than as a consumer. So I might switch a bit between these 2 wording. So the program, so we call it CARE, Consumer and Researcher Engagement Program, facilitates actually beneficial and meaningful connections between a researcher and a member of the community who have lived this experience, has the disease we are studying. And I say really meaningful connection, which means for us, we do not want to have a signature one day before the grant application has to be submitted, saying, oh, can you please read through that and give me your signature? Yeah, we try to educate our researchers to say you need at least 6 months with your consumer to build up a relationship before you can ask them to sign an application for you. Otherwise, they don't know what you're doing. You do not know what your consumer is doing. And yeah. So that comes to actually really the question why we're doing it. We really would like to have an effective engagement with the consumer, and we would like to ensure that as well. And our program has a buddy system as well. So we're launching our interference with, or the connections we're having with the consumers, advocates, so that the committee can look at it and say, hey, you haven't contacted your consumer for quite a while. Would you let us know, please, why? Or do you need any help, how you could connect with your consumer? And if you need help to engage with them, please let us know. We're looking for people of all ages, diversity, and lived consumers. So the Australian Centre for Blood Diseases is focused on blood disease, as it says. However, we extended the program to the whole CCS. So that means we have dementia, we're having a lot of neuroscience disorders, and yeah, we like to involve all people, ages, diversity with lived diseases. So how could that work in our program? It's really up to the individual. It's tailored to their time availability. It's just a discussion between maybe the PI and the consumer, or it could be reading the grant proposal, reading the overall project and give feedback to it, provide plain language summaries for researchers, because when we're writing a plain summary, it might be not as plain as we think it is as a researcher, and we might have to find other words than the word protein or antibody, and so we really have to work on that. We did a lot of meet and greets so far, so we try to avoid, give back to the community as well information about diseases. So we run webinars. We really would like to advocate for the research we are doing here at the CCS. But as Susan was saying, we need as well to change the thinking, the culture of researchers, because it is not just time commitment we have to put in. We have to make clear what the researchers can get out of it as well. And we found that the main thing we're getting actually out of it is motivation. Because suddenly the protein you were studying has a name, it has a disease, and it has a person who has a disease. And it's really, really important to see that, especially for young researchers. And then it comes back again to this development of the relationship between the researcher and the advocate. We really need to see as well that the advocate is a person, and it should be treated as a member of the team. It should be a two-way discussion, as Andrea was saying as well, and not as a signature in the end of the day. We would like to give a voice to consumers as well. So if we are running webinars or seminars, we would love to have consumers involved to give their opinion to research, to the topic, and actually telling us what is their main issue, as we have heard before. And we believe that they should, because research is paid by tax money or philanthropic money. So it is the community money we are actually spending in our research. So they should have a voice to it. I think, yeah. Thank you.
Karen, thank you so much. And some really positive comments in the chat to people involved who really feel genuinely cared for in engaging with your group. And thank you so much for sharing your experiences today. I'd like now to invite Sandy Reader to talk a little bit about the Monash Partners Consumer and Community Involvement Platform and some of the findings from our research. Sandy's also led a lot of the work on behalf of Monash Partners around supporting and advising researchers across our network. And Sandy, I'm sure there's some learnings that have arisen for you from that work, and perhaps also some of our resources. So over to you.
Thanks, Angela, very much. We've been doing some really exciting and interesting research in consumer and community involvement, which we started back in 2019. So our main objective has always been to develop workforce capacity building program that would strengthen consumer and community involvement in health research as well as healthcare improvement. So we started with a scoping review to examine what kind of training content or guidance was available to assist us with preparing researchers and healthcare professionals for consumer and community involvement. So we, after reviewing the published and grey literature, we had 6 full text papers, 7 websites, which basically told us that there wasn't a lot of evidence-based guidance to assist us in developing this training. So from that, we then did a qualitative interview study to explore all this further, where we spoke to representatives from consumer organisations, universities, health services. We completed 28 interviews and a focus group, and these results gave us some good insights into the barriers and enablers to meaningful CCI for healthcare professionals and researchers. And an enabler was particularly to have training in this area. And some of the barriers came out as a lack of time, resources, and difficulty finding consumers. The research has also given us some great information and insights into training needs, what those particular needs are, what the priorities are, and some content for education and training. So both of these topics and areas are either one's been published, so barrier enablers, this has been published in Health and Social Care in the Community, and we're in the process of publishing the other work. But this research work has really helped to inform, plan and deliver Monash Partners resources and education in consumer and community involvement. So we have our online training modules, which is 6 self-paced modules that enable pretty quick and easy access to high quality information that is freely available for everybody to work through. We have a number of links and websites to go through, videos and toolkits, because we acknowledge that there is some really great information already out there. So we link you into that. Our research work has also helped inform some lunchtime series webinars that we run and hold several times a year, as well as some collaborative webinars where we've linked together with other advanced health research and translation centres, in particular a very productive one with Sydney Partners in working to help people who work in the particular area of clinical trials to do consumer and community involvement. We've also collaborated with Western Australia's Health Translation Network for programs, and they've been really helpful to strengthen and advance our CCI program. Our research has also informed a number of education presentations that we've done into implementation science masterclasses, as well as a Masters of Public Health, and the number of invited presentations that we get to do. We've developed a remuneration and reimbursement policy and guidelines. It's also available on our website. And also we've, in the process of developing all of this and the research work that we've done, we've also collaborated and connected with international experts, particularly from the UK and Canada, who have really helped us to shape the work that we've done. We've got some new research as well, where we're looking at models for consumer advisory committees. So we're conducting some scoping review, interviews, focus groups to look at the best evidence to help us establish consumer advisory panels according to some of Monash Partners' clinical themes. So we may have a consumer advisory panel that may not necessarily be project dependent, but may support the numerous projects and provide advice and feedback on for grants and further research. And with respect to our particular advice and support service, well, as I mentioned earlier, some of the barriers to consumer and community involvement have been identified as actually not being able to find consumers or not having resources or knowledge around it. And so this service has been helping to overcome those barriers. And we talk to people who have a range of experiences. Some are new to CCI, some are already doing it but want some more information. And some people just want to support others in doing it. So we help them with all of those particular areas to find consumers, incorporate it in their work, and just help them with where to start. And a lot of it's reassurance and referral to resources. So this service has been really positively rated. It seems to be a really valuable component of what Monash Partners offers. And I'm pretty confident that this service has helped to build capacity, and that there are many researchers out there now doing some genuine CCI and engagement related to the opportunity to being able to talk about their projects, have it contextualised and individualised to their particular needs.
Thanks so much, Sandy, for highlighting the work that's been happening over the last 3 years. It's been terrific to work with you, and a nice segue. There's been an enormous amount of work done over many years in Western Australia, and our next speaker, Keith Hill, spent a number of years working in WA before returning to Victoria. And Keith, I think everybody would be really interested to hear a little bit about your own journey around involving consumers in research and what some of your learnings have been. And I'm interested in your thoughts about what needs to happen to strengthen it and take it even further. Obviously, we've made a lot of progress, but we've still got a lot of work to do. And in your leadership role, what kind of strategies are you implementing to foster that culture of consumer and community involvement and change in your own research group? Thanks so much. Over to you.
Thanks, Angela. So I've been actively involved in research for something like 30 odd years, and so I've seen a lot of changes over that time. Back in the early days, this sort of thing was not a consideration at all. The researchers came up with the questions, we did the research, we disseminated, and we hoped that it had some degree of impact. As we've heard from a number of the speakers today, often we don't have impact, and some of that goes back to that very issue of not engaging consumers and community in every aspect of the research that we do. So over time, clearly this has become a priority at a national level through NHMRC and filtering down, and it really should be core practice for every researcher. And it was very interesting to hear Karen's work, looking at it from a lab perspective. I've heard many people in those sort of areas that say, well, how can I, who are the people, as Karen was talking about, but it can be done, as was described there. In WA, they have had for a number of years a bit ahead of Victoria, a key group over there that was trying to drive consumer engagement in research. And I think Monash Partners here have really picked up the ball and done a great job in progressing the areas here. What I've seen in the past 3.5 years, I came back to Monash 3.5 years ago to set up a new research centre, and it was probably a bit of serendipity, and it's actually given me food for thought about how to introduce things. And how to do it if you're in a very well-established centre, or as we heard in one of the questions early on, in a well-established longitudinal study that hasn't been engaged with consumers. How do you actually get that happening at this time? Because it should be happening. For me, with setting up a new centre, it actually was a ripe, fertile ground for us to set this up. And so we set out with policies and procedures and so on within our centre to try to make everything that we do from the start having a consumer and community engagement focus. We also, at that time, started bringing on, we're only a very small centre, and we brought on our first few staff, and the couple of staff that we brought on, a bit by chance, but also through this thinking about how we wanted this centre to evolve, had very strong personal practice with respect to consumer and community engagement already. And so these two people, Associate Professor Libby Callaway and Dr. Tash Pushko, two of the stream leads within our research centre, and they, together with myself, drive and make sure that everything that we do within our centre, from concept through to implementation through to dissemination, actually does include, as best as possible, degrees of consumer and community engagement. We still don't get it all right, and I'm sure Margaret, who's coming after me, will probably allude to a couple of areas where she's helped us to come back on track. It is a challenging area, and I think it's extremely valuable to have a good relationship with the consumers that are involved in it, and to be able to be very frank when perhaps we as researchers are not doing things right, to be confident to give that feedback back to us. In terms of strengthening community and consumer engagement and some of the barriers, I think one of the challenges we've got as researchers, sometimes we've got good opportunity to plan long-term the sort of things that we do. Some of our grants are annual grant rounds, so we can start 6 or 12 months in advance, as has been suggested. But there are times when opportunities come up from left field and are very sudden and have a quick turnaround time, 6 or 8 weeks, to develop a proposal, bring together a team, and get everything together, including the valuable consumer and community engagement elements. And that's really, really hard. In our centre, we're quite diverse, having rehabilitation, ageing, independent living. There are effectively 3 different centres in a way. So we've got a very diverse mix of potential consumers in the sort of research that we want to do. And so even though we may have what we need to be doing over time is constantly interacting with our consumers and community around what are the priorities, what are the things we should be researching, and so on, we sometimes need to be able to jump quickly into a new grant opportunity. And that's where having that relationship, even if you haven't worked for 6 months on this particular grant and worked it up from scratch, if you've got the relationships there, you can move quickly and get these applications in quickly. In terms of embedding, I think being a news centre, we've been able to do that, but it is around trying to set up, there's things you can do as an individual researcher, and there's things that your centre or organisation need to do. And so you need to have those policies and procedures and some way of reviewing and monitoring that your researchers at an organisational level are practicing what we want happening in this space. And as an individual researcher, even if your organisation or centre is lagging a little bit in this space, you can still pick up the ball and run with it and implement it in your own research practice. So I think those are things that are valuable going forwards. As a centre, and I think many centres do, we are developing a fairly strong consumer community grouping, which we're calling Friends of Rail. And that grouping is going to be what's going to, in future, inform a lot of the research directions that we undertake. So I'll leave it at that, Angela.
Thank you so much, Keith, for sharing your wisdom and knowledge. Greatly appreciated. Margaret, I know you've had the opportunity to work with Keith and his group for some time now, and we'd be interested to hear from you a little bit about what it's meant to be involved in the research program, maybe how it's influenced some of your thinking or perspectives on health and healthcare, and maybe what are some of the things, what your advice to researchers or some of the things you'd like them to ask or engage with you around. Over to you.
Thank you, Angela, and thank you also to Keith for giving me the opportunity to be involved with his consumer group, or his research group, I should say. But what being involved with that group has done is it's given me quite an awareness of the amount of work that it takes to get funding for the projects. I mean, you only had to listen to Julie and Susan a little earlier and to see the amount of work that they've been doing, you know, in their particular areas of interest. And also, I've also seen the time it takes to develop submissions for projects. I've been sometimes a little concerned when I see just how tired Keith will look when he's been sort of putting in submissions to try and get funding to do the various projects that he wants to do. And the other area, of course, is to get sufficient participants to give projects authenticity. I mean, Susan made comment, you know, that for a while there, they just wanted to opt out and, you know, sort of getting someone to stay the course, shall we say. Also, the challenge to get authors to write the various research papers in English text that older people or people who have less than adequate English skills can understand. There's some of the things that I think has been raised in this by a number of people. You just have to sort of say, it's almost the text that a 9-year-old child would understand, so that you're not alienating people from it. And of course, that comes down to the area of the culturally and linguistically diverse group and the Aboriginal groups, that many times the texts are written for people who understand English. Those who are less skilled are not quite so able, and that worries me a little. But how has it changed my perspective on health and healthcare? And I think we probably need to better educate people to understand how much we as individuals are responsible for our own life path. The food we eat, the amount of alcohol and drugs we ingest, and the exercise we do or don't do. I mean, these are some of the things that I think as individuals we need to take on board. And healthcare in Australia is amazing, and there's many skilled and caring clinicians, but without adequate funding from our various governments and philanthropic areas, you know, and the system will be under stress. But it needs to be well used, and it's in the researchers' best interest to show how it is being used. And I suppose the areas that I'd still like to Keith and his team perhaps, you know, to sort of consider is, you know, that there is a lot of health and financial literacy still to be covered in this community. I get very concerned when I sort of talk to people who can't read what's on a medicine bottle. They have done very little to put wills or powers of attorney in their lives. And my final thing that I think I still would like to know about is how do we encourage lifelong participation in active and health exercise programs so that we can maintain good health into later life. Thank you.
Margaret, thank you so much. Some really terrific points that you've raised, and I think will be really helpful to our research community online. A sincere thanks to all our presenters. We've got a little bit of time now for some Q&A, so I'm going to hand over to Helena. There's some questions that have come through in the Q&A and also in the chat. Helena, over to you.
Thanks very much, guys. As always, I always really enjoy listening to the stories and the experiences. So just in terms of a few of the questions that have come through. So to Julie, first of all, how do you manage to get that collective of people affected by CF? How do you reach out to them without breaching privacy laws? Have you got social media groups? What are your strategies for communication? Because I've seen how effective it is with getting everyone together for your 65K events.
Yep. So we are a really close-knit community. So I think with any condition when there's not, affecting children as well, I think it gets buy-in from parents. You're really keen to look after your children sort of as soon as they're diagnosed. So we're very active on Facebook, but we work really collaboratively with the 3 cystic fibrosis clinics. So with each of them, they all advertise our event to the whole cohort, including our website, our Facebook account. So and then people join us from there. So we're not putting the CF community under any pressure to join us, but they certainly receive information that we're there and what we're doing, and they can opt in.
Great, thank you very much. Now there's another question here about priority populations, so underserved populations and how we engage them. And I think there's a big challenge around this. I'll get any of you are welcome to respond, but I think there's always the issue of elite capture of people who are articulate and educated and who can engage in, for example, governance of trials. But one of the big challenges is reaching out to people in the community. And I know Monash Partners had a recent activity with the Department of Health where we actually got together quite a large group of stakeholders, and in fact the majority, if not all, were from diverse and underserved populations. But it can be more challenging, and some of the ways at least we've done that is through the interfaith groups and the community groups, and local councils actually are also quite good in terms of reaching out to communities. And the other thing obviously is to think about reciprocity. But can I ask all of you if you've got any hints or tips that you would like to put forward about engaging underserved communities in a meaningful way? Does anyone want to take that difficult question?
That's really difficult, Helena. I don't think I can contribute, but it's hard enough engaging, I know, with a community that is pretty much all Caucasian, and it's really challenging. Sorry, I've opened my mouth without really having a solution at all, other than acknowledging it's extremely challenging.
I think, Julie, we would agree with you. Keith, you were going to mention something there?
Yeah, again, I think often as researchers we take the easy way out, and when we're actually implementing our research, we're going to the well-used, likely to be successful recruitment avenues and so on. And so we end up often with a population that is not the target group. In my area, for example, in ageing research, you want a very diverse group of older people, different socioeconomic backgrounds, different education levels, but we end up often having people from the upper ends of those spectrums involved, and that's because of the way we recruit. And so I think in our planning, in our engagement with consumers and community, and in our implementation recruitment methods, we need to really try to get buy-in through some of these more perhaps less easily identified and reached communities. That just means legwork and developing relationships, and it's hard work, but that's what we as researchers have got to be doing more of.
Yeah, Keith, I agree. And if you look at groups, for example, like the Burnett, who've done some amazing work with hepatitis B, with HIV, with different groups in the community, they have phenomenal grassroots consumer and underserved population engagements. And a lot of it's about deep, long-standing relationships. In a way, the principles are the same, Julie, with the way we work with CF. It's a long-standing relationship, but it's about building up those relationships. And definitely, at least for my research group, we do a great deal of work with cultural linguistically diverse groups. Some members of the team do a lot of work with Indigenous and Aboriginal and Torres Strait Islander populations. but definitely quite a lot with the culturally linguistically diverse groups, with the migrant groups and agencies, both at a state, federal and also regional level. But often when we want grassroots connection, we go very much locally. And it's about even the health services that are supporting those groups in the community. So I think the reality is that it's important and it's hard, and often it's not the first point of call, but it's something we really need to get behind. Margaret, you've got your hand up there.
Yes, I was going to say, one of the things that I've noticed over the years, especially when I did work with the department, was the difficulty with the Indigenous populations, because they are such a diverse group. So I don't think you should beat yourself about the head too much, because what will work for a Victorian group of Indigenous populations won't necessarily work in Western Australia or Northern Territory or Queensland or New South Wales for that matter. So I think that you can make an effort to be involved through, say, the local Indigenous population, but you also need to recognise that they don't speak for everyone.
Yeah, no, definitely. And that's the other thing, to avoid representation, if you know, depending on the role. So thank you, that was useful. There's a question here about have we seen much evidence of researchers building into their reporting about how they go about consumer and community involvement and the value and benefit? So it's interesting, we've Monash Partners has done some work around this, and we've actually got a current submitted large grant, which is actually looking at the issue of best practice. So how do you best do this from an evidence-based perspective? There's not a lot of research around this. Andy's described some great work they've done around training needs, but surprisingly, there's not a lot of work around actually which is the best way to do this. So that really is an area of research at the moment. In terms of your articles, I don't know whether anyone else wants to comment, but journals, for example, like BMJ, you have to make a statement about your consumer and community involvement. And definitely in the UK, it is absolutely standard, and you'll find it in many of their papers around what the involvement was and how it was done. And they are much more professional and advanced in some ways than we are in Australia. So I think that, you know, if anyone else has got anything to add there, but definitely increasing in publication and requirements. Did you want to comment on that at all, Karen?
I think it fits really well here to say that's not every engagement fits to everyone. It's really depending on the research. It's depending on the constellation you have between the researcher and the advocate. And we have seen great involvement here, from I have no idea what to do with a consumer to, oh yeah, we're meeting up once a month. And we really try to change the point of the researcher, that it's just time for them just to say what they're gaining to be having an advocate involved. And it seems to be, it's slowly changing. It's a process which will change, which will need years and years to change. And what we really need is the government saying you need to have a consumer involved, full stop. I know that the MRFF grants are already do that. However, ideas grants, for example, do not do that. And you do not need a record. You need a statement, but it would be nice to see that the government says as well, hey, can you prove it somehow? Do you have a record of it, and not just, yeah, here's a lay statement of what my consumer has written.
Yeah, no, definitely agree. So there's that systems and policy change, and then there's the operationalisation, which is what Monash Partners is trying to support. Yeah. Thank you, Karen. So there's a comment here about the effectiveness advisory groups really about, you know, what their role is and how they work professionally. And it's definitely true. You've got to always be careful you don't actually create a different form of professional in supporting your consumers, only working with one group of consumers. Indeed, they've seen that a lot in the UK, but that's always a challenge. But, you know, people who are genuinely committed to the area is important. There's a message here about people who want to reach out to the more underserved populations and being careful about specific networks. So again, I think that, you know, there's a lot of easy ways to do that. There's a lot of community grassroots organisations who work directly with, you know, with refugees and with humanitarian populations and others. And it's a matter of thinking about the organisations you're reaching out to, not necessarily as representatives of different groups, but actually as people who are, you know, on the front line. I know definitely in Monash Partners, we're right in the middle of that population. We've done a great deal of work directly with those populations, but it does take effort, it takes connection, and really takes an awareness of the fact that you can't have people speak on behalf of everyone, as you highlighted, Margaret. You can't engage everyone, but if you're working in areas where really the populations are the most underserved, we do have a responsibility to do that. Yes, totally agree, John. It's vital we do have a diversity of voices from consumers or from patients. So on that, that's fantastic contribution, everyone. Really greatly appreciated. I think you know, really some fantastic discussions there. I've really enjoyed the discussion. I think you'll get a recording. I think starting the day with Susan's passionate positioning of where we are and why research is important is so good. I have to say to Julie and Susan, I've always worked in this field, but I've really appreciated working with both of you and learned a lot in the journey. And it's really quite a sophisticated process now. So it's been fantastic. And for the sharing from the rest of you, I really appreciate your time and contributions. And I think I'd just finally like to really acknowledge two people. So the first is actually Sandy. So Sandy's our fellow at Monash Partners and just does a fantastic job of supporting and engaging others. Very experienced in consumer involvement herself, but really has been fantastic in terms of advising many groups across Monash Partners on how to do this. But mostly I wanted to thank Angela Jones, who's been pretty passionate about this area and has really led the program for Monash Partners, but not just for Monash Partners, has had a lead role in the national initiative. And has really done some great work in this space. I'd encourage you all to look at the Monash Partners resources online. Please give us advice if we can improve them in any way. But I think it's actually really important to reach out. And if any of you have got suggestions about engaging, for example, with underserved populations, please do bring them to the table. We're always interested to listen and work with anyone we can. But I just wanted to acknowledge the pretty passionate passion that Angela brings to this space. Otherwise, on that note, thank you very much, everyone, and thank you to the people behind the scenes, including Victoria and Joe Ong, who's one of our fellows who works in this area in Victoria, who makes everything run well. Thanks to our panellists, and I hope you have a wonderful rest of your day. Thank you.
Thank you.
Thanks, everyone. Thanks, Selena.
Thanks.